Melanoma is a serious form of skin cancer that starts in the pigment-producing skin cells called melanocytes. Melanoma is the fifth most common cancer in North America, and the number of melanoma cases diagnosed annually is increasing faster than any other cancer. In contrast to other types of skin cancers that usually develop on sun-exposed areas of the body, melanomas can develop anywhere on the skin surface. This includes the palms of the hands and soles of the feet, as well as the lining of the mouth and nose. If left untreated, melanomas can spread or metastasize to other parts of the body, much more frequently than is typically for other types of skin cancers. Fortunately, when detected at an early stage, melanoma treatment is often effective in preventing the spread of the disease. How do you diagnose a melanoma? Similar to other types of skin cancer, melanoma is diagnosed based upon the appearance of the skin lesion. Melanomas usually present as a changing mole or a new mole, most often with dark pigment. They can occur anywhere on the skin, including on the back, the scalp, and other areas that may be easy to miss with self-inspection. Abnormal findings can be described with the acronym ABCDE. A for asymmetry, which is one side is different from the opposite side. B for border irregularities, which is jagged, uneven edges. C for color variation, i.e. different colors within the same region. D for diameter greater than 6 mm, and E for evolution or change in color, shape, or symptoms over time. Other abnormal features include inflammation, which is redness around the mole or swelling, and bleeding or crusting. To determine if abnormality is a melanoma, a small piece of the abnormal skin, or if the entire area is removed. A biopsy deep enough to include the deepest part of the lesion is preferred. The biopsy is then examined under a microscope to determine if the precancerous or cancerous cells are present. How serious is my melanoma? Once melanoma is diagnosed, the next step is to determine the clinical stage or extent of disease spread. Accurate staging is important to determine the most appropriate treatment. The staging system for melanoma takes into consideration the following characteristics: the thickness of the tumor, ulceration or loss of skin over the surface of the melanoma, mitotic rate or the number of dividing cells in the tumor per square millimeter, the involvement of the regional or nearby lymph nodes or the lymphatic vessels that lead to them, evidence of tumor beyond the lymph nodes called distant metastasis. Now, a thorough history and physical examination are typically performed to evaluate the possibility of lymph node or distant spread of the tumor. Imaging tests may also be recommended, particularly for patients with advanced melanoma, those with previous melanoma, and those with signs or symptoms that may be suggestive of metastasis. Possible tests include a chest X-ray, a computed tomography or CT scan, positron emission tomography or PET-CT, or even a brain magnetic resonance imaging MRI scan. Once the staging workup is complete, a pathological disease stage between stages 1 through 4 is assigned. A higher stage indicates more extensive disease. Stage 1 disease, the tumor is less than 2 mm thick, and surgery alone is curative in greater than 90% of cases, meaning the cancer is completely removed and not likely to return. Stage 2 disease, the tumor is greater than 2 mm thick or greater than 0.8 mm thick if ulceration present. Patients are at a higher risk of developing recurrence even after the tumor has been completely surgically removed. Adjuvant, which is additional therapy, is often recommended. Stage 3 disease, there is evidence of melanoma spread to the nearby lymph nodes. The tumor may be any thickness, and adjuvant therapy is strongly recommended in stage 3. Stage 4 disease is when the melanoma has metastasized or spread to distant locations in the body. The tumor may be any thickness, and based upon the pathological stage, the optimal treatment for the treatment is necessary. With metastasis, the goals of treatment are complete surgical removal of the primary melanoma, evaluation of the regional lymph nodes for evidence of tumor involvement, and preventing further spread of disease recurrence. How do you treat melanoma? In most patients, surgery is required to remove or excise the entire melanoma. Generally 1-2 centimeters of normal skin surrounding the entire lesion must also be removed. This procedure is called a wide local excision. This decreases the chance that the melanoma will recur at the same site. Most patients are able to go home later the same day. Complications include bleeding, infection, and a chronic wound. If an enlarged lymph node or gland is present, it may be biopsied, often prior to the wide local excision, to aid in surgical planning. Even if enlarged lymph nodes cannot be detected, the lymph nodes frequently will be evaluated during the wide local excision procedure. The most common site of melanoma spread is the lymph nodes draining the area where the melanoma was detected. Sometimes lymph node involvement is obvious because an enlarged lymph node can be felt. In this case, removal of all the lymph nodes in that area, called a therapeutic node dissection, is the standard approach. Therapeutic node dissection provides opportunity for a cure of the melanoma. In the majority of cases, enlarged lymph nodes are not visible or palpable, and the only way to determine if lymph nodes are affected is to take a sample of the draining lymph node during surgery. This is typically accomplished with a surgical technique known as a sentinel lymph node biopsy. The sentinel lymph node biopsy technique is based upon the theory that when tumor cells migrate, they spread to one or a few lymph nodes before involving other nodes. These nodes can be identified by injecting a blue dye or radioactive material around the skin cancer before the wide local excision, and then searching for the node that absorbs the dye or radioactive tracer at the time of surgery. Sentinel lymph node biopsy is usually done at the time of the wide local excision. The status of this first draining or sentinel lymph node accurately predicts the status of the remaining regional lymph nodes. Because only one node is removed, or at most a few, the risk of this procedure is lower than full lymph node dissection. Common short-term complications include wound infection and breakdown, seroma inflammation. Long-term complications include lymphedema or swelling and numbness. After the lymph node is removed, it is then thoroughly examined under a microscope to determine if the melanoma cells are present. If the biopsy comes back positive, meaning it showed cancer cells, the person can be monitored with observation and ultrasounds at regular intervals. Then, if an exam or ultrasound shows cancer in those regional lymph nodes, these lymph nodes will be removed in a procedure called a completion lymph node dissection. Avoiding or delaying the removal of the regional lymph nodes reduces the risk of the complication of lymphedema, which is a swelling caused by buildup of fluid in a limb near where the nodes were. If the sentinel lymph node biopsy identifies the draining lymph node and it comes back negative, further lymph node dissection is not performed, since the likelihood of finding tumor involvement is less than 5%. Sentinel lymph node biopsy has become the standard technique for assessing the regional lymph nodes and is recommended for staging of most people with newly diagnosed melanomas. However, certain people whose melanomas are very thin, less than 0.8 millimeters as measured under the microscope, and who do not have other high-risk features, do not require sentinel lymph node biopsy, since the likelihood of tumor spread to the regional lymph nodes is less than 5%. The term adjuvant therapy refers to any additional anti-cancer treatment that is given after the cancer is surgically removed. The goal of adjuvant treatment is to stop or slow the growth of any remaining cancer cells that were not removed during the surgery, and to decrease the risk of recurrence. Immune therapy, also called immunotherapy, refers to drugs that work with your immune system to do this. The drugs nivolumab and pembrolizumab, called checkpoint inhibitors, are the most common immune therapy that enhance the body's own immune reaction against melanoma and have been used as adjuvant therapy for people with melanoma who are at high risk for recurrence. How do you follow up melanoma after treatment? Because melanoma can recur in the same location or at new sites, routine follow-up and monitoring are very important. Seeing a healthcare provider regularly is the most important aspect of follow-up, since most recurrences are discovered when the patient is seen and examined at regular intervals after the treatment. Imaging studies such as CTs or PET-CT scans are usually recommended only if new symptoms or physical exam, blood tests, or chest x-rays show abnormalities. These more advanced imaging studies may also be done on a regular basis for the initial 2 to 3 years in patients with high-risk stage 3 disease.